It's great to be back at Mission Bay for this meeting, I'll have to say. Great venue, and to be on a UC property is wonderful. One of the privileges I have today is to introduce our 67th Abbott professor, who is now officially part of the Minnesota Mafia that Jen Lane outlined nicely in Grand Rounds yesterday. The number of individuals that have been back and forth between the University of Minnesota and UCSF over the years has really become quite significant, and it's a great group. I noticed as I looked through his list of publications that co-authors included Patrick Horst, Carol Lynn, Reza Firuzabadi, all graduates of our program, and he's been a mentor to our current fellow. Dr. Schmidt is well known in trauma circles. He's a professor of orthopedic surgery at the University of Minnesota. He's been the chief of surgery at Hennepin. He graduated from the University of Colorado, did his medical school at UCSD, and then his orthopedic training at Oregon Health Sciences. And then that was followed by a fellowship at Hennepin County Medical Center with Dick Kyle, who is kind of the first person to do this traumaplasty that you're going to talk about. Dick being a member of Trauma Association and the Hip Society and crossing that barrier. Dr. Schmidt's been awarded for his research. As you heard, he's been part of these multi-center trials, the metric study, which received a Kappa Delta award. He's been a visiting professor many places. The one that I picked out that was interesting to me was at the Landstuhl Regional Medical Center in Germany in 2010. That must have been a very interesting experience. He's been a leader. He was the president of the Minnesota Orthopedic Association, president of the Orthopedic Trauma Association, and then a funded researcher. And you've heard about some of his work in compartment syndrome this morning, and you'll hear more. Really delighted to have you with us. Thank you for joining us, taking the time, and we look forward to your comments, Andy.
Thank you. Well, it's my pleasure to be here. I do feel a strong kinship with this program. The trauma faculty I've known, but many other UCSF faculty I've worked with in other roles, Colleen Sabatini in her role in that International Committee for the Academy, for example. Dr. Gudrun Myrick, now Myrick Mueller, is one of my partners at Hennepin, was a fellow here. Brandon Kelly is one of our residents who's now a fellow here. And we've just had a great relationship over the years. So I did want to talk about traumaplasty. This was a talk I didn't just come up with recently. I was asked to give it several months ago, kind of to talk about how my career progressed and kind of found this niche that we now call traumaplasty. That's not what was ever my plan at the very beginning. So it's interesting how you end up doing what you do. I don't have any relative disclosures to this topic. So I want to define what traumaplasty is. I think we already know, and its role in current orthopedic practice. And then also get it at the end a little bit about just the importance of how you kind of define and I think maintain complementary skills as you progress through your career. So this portion of the talk would be good, hopefully, for the residents and fellows to hear if they're in the audience. And so we'll get going. So this is a fun thing I kind of played with, words that weren't in the dictionary and maybe aren't in the dictionary, traumaplasty being one of those. So circa 1993, that's the year I finished my fellowship in Minneapolis. I like doing trauma, I like doing total joints, but they were sort of separate. But there was cases where they interacted, so we had to treat complications after fracture fixation, whether it was post-traumatic arthritis, like the plateau fracture you see, or a failed hip fracture fixation, like you see there on your right. And when we did acute arthroplasty for fractures, it was really femoral heads and humeral heads, and it was hemiarthroplasty, and this was done by the trauma surgeons and kind of mobilized the patients, but we didn't care so much about outcomes back in those times. And what's interesting now is we still do arthroplasty for those same fractures, but instead of hemiarthroplasties, it's now reverse arthroplasties. We just heard a lot about that. Total hip arthroplasties for the femoral neck fractures. So surgeons that require a little more technical expertise, a little more complicated, especially I think with the reverse shoulders, which I have decided not to do. But we also have periprosthetic fractures are becoming more and more common, and a lot of controversy. Do you fix them? Do you replace them? In traumaplasty, you have potentially both options, and then the role of acute arthroplasty for even more perarticular fractures. And we saw a good case this morning of an acute arthroplasty in a geriatric acetabular fracture patient. And these are just recent examples of some cases, kind of my traumaplasty practice with periprosthetic fracture, failed fixation, and then some acute knee arthroplasty for, in one case, less common in a plateau fracture, but this was a case that I didn't think I could fix very well in an elderly patient. And then distal femoral replacement is having a larger role for supracondylar fractures in the elderly. So how did I get to where I am? So Dr. Vail talked about my residency in Oregon. Rod Beals was the chair there. Sadly, Rod died in 2008. But some of the older faculty may have known Rod. Pod DeWillius just retired. He had just come up and started his as a junior faculty member from finishing his trauma fellowship at Davis when I started my residency. But Oregon had at the time a very strong clinical residency. Fantastic trauma training at OHSU, which was a level 1 trauma center. We also got great training in primary and revision arthroplasty, even as residents. And then I went to Minneapolis to do my fellowship with Dick, and that's because I like doing joints, I like doing trauma. This is a picture of Dick Kyle on the right and Ramon Castillo on the left. I thought those guys were old when I was Dick's fellow. They are both still practicing, which is pretty amazing. Ramon is now in his 90s and working in the Philippines. But they were both very active. And so I worked at an institution where both trauma and arthroplasty were really part of the institutional heritage with primarily these two fellows and the careers that they had. So I picked 1996 for a reason. I was a few years into practice. I was doing my trauma call. I had a very general orthopedic practice at the county hospital. I was doing a lot of the total joints that needed to be done in the lower extremity. Even back in those days, I was doing total shoulders, which I've stopped, but a lot of general orthopedics, and there's just the rare overlap I've already talked about with trauma, and it was the shoulder and hip hemis, and perhaps the rare periprosthetic fracture that we saw, and those were largely around cemented implants in those days and were revised. But I dug up this case as an example of something I kind of managed with arthroplasty of fractures. This is a patient obviously with a very arthritic knee, so that's probably, or that is the reason why I decided this patient needed a knee replacement, but I had to deal with the fracture. So just did a simple internal fixation, unicortical screws, and a larger leg screw kind of behind the prosthesis, and did a revision type knee with stems and posterior stabilized, and kind of applied my two skill sets to what I thought was the best solution to this particular patient. And this is just a follow-up film that I saw. So this is 1996. This was a woman that came in. She was 64. She was rollerblading. She had this fairly odd, injury to her hip. You can obviously see the bone fragment lateral to her acetabulum. Obviously, the hip is not congruent and is subluxated, and the CT scan really tells the story. And so I reviewed this with my colleagues who did acetabular fractures, and obviously there's a lot of femoral head damage, and she was very active. So I did a total hip on her, and didn't even have to worry about the fracture being sort of an anterior wall fracture. And this woman did great. I remember this was presented at our fracture conference, and my senior partners weren't so thrilled that I did a total hip for this. But we looked up later as part of a study we did, and it served her well for the rest of her life, which sadly was more brief than she had thought it would be, dying of cancer just 4 years later. But now 10 more years go by, and I'm working along, and in retrospect, the arthroplasty and the trauma really became more and more intertwined. So more and more of these acute arthroplasties for fractures, even beyond the femoral head and the humeral head, we began to do them in acetabular fractures, as I just saw. We were doing some in distal femur fractures, and then many, many more periprosthetic fractures, where there's just what I find an academically fascinating argument about whether you should fix them or replace them, which I'll show a little bit more later. So the traumaplasty of my practice has gotten a lot bigger. And as I reflect on things looking backwards, I really do, I think, see fractures, in some cases, joint cases like periprosthetic fractures, differently. And I think I make different decisions with the expertise that I've kind of gained using both disciplines. So this is just a simple pre-op x-ray that one of our residents showed at our joint indications conference a few weeks ago. But whenever I see a lateral x-ray of the knee and a tibia, I'm imagining how I might nail it. I just can't help it. But what's fascinating to me is you see that difference in the offset between the tibiotubercle and the joint surface and sort of the posterior displacement of the knee. I've never heard a joint surgeon talk about that in pre-op planning, but I look at that and, I start wondering what effect it's going to have if, trying to get the tibial component properly aligned, is it going to be, if I do the wrong starting point, which I'm thinking about all the time in nailing, is it going to affect, and am I going to get an anterior tilt or whatever? But, those are just examples, I think. So here's some interesting cases that I think I admitted differently with my sort of combined experience. This is an 89-year-old male, came in as a trauma patient with after a motor vehicle accident, had a severe type 3 open distal femur fracture. He was hypotensive. Had a large wound. We took him to the OR, and being really familiar with the damage control concept, I was quite happy to do that, with my trauma training. And so we washed out the wound. We put him in an X-fix. We took out the devitalized bone fragments, put some antibiotic beads in, just the same way we would treat any open distal femur fracture in really any patient. And put a couple lag screws across the condyles in case we couldn't get back to him for a while. Wouldn't have to worry about that reduction. And he stayed in the ICU, was pretty sick for quite a while, decided not to do the follow-up IND we'd planned because he was so sick and his wound looked quite benign. But all of a sudden, 2 weeks later, he's actually well. He's out of the ICU. This is really an isolated injury. His knee wound, traumatic wound, was very well healed. The pin sites were okay, but I was going to have to do something. And after talking to him and his family about the options, this is the distal femur replacement we sort of planned out. And this is probably pretty commonplace in some institutions, but remains rare in ours. But I think for this gentleman, it was the right thing to do. And I was quite comfortable with that, with my joint practice experience. So here's another case, 63-year-old woman. So now, at the time I viewed it as old, and it's quite young to me now, but head-on collision at highway speeds, intubated in the field. She had right pupil was blown. She was hypotensive, very hypotensive. She had blunt chest trauma, multiple fractures. She was morbidly obese, but she was a farmer's wife, lived on a farm, and that's always a good prognostic factor for any of you that have been in the Midwest. But she was in the ICU on pressors for quite a while. One of her IVs infiltrated, and she lost her hand later on as a result of that. But it required quite a while to get her stabilized. And these are her some of her fractures. This is her AP pelvis, so you all can see the comminuted, very displaced femoral neck fracture. You can get a sense of a pelvic ring injury. And she had a acromial fracture that was very comminuted, forearm fracture, foot fractures. We could do really nothing but put her in skeletal traction initially. And so she remained in the ICU in critical condition for days. She developed full-blown ARDS, was intubated for quite a while. We found out she had an adrenal insufficiency, which perhaps explained part of her initial hypotension, but nonetheless, she still was very, very ill for quite a while. And here's just a 3D CT of her pelvis. So a week after injury, the ICU team was really pushing us to fix her hip so that she could be mobilized. I was the responsible attending, and I couldn't really think of a good way to fix her hip that would really allow her to be mobilized. She was still had a completely uncertain amount of cognitive recovery. She was still in the ICU. She was off pressors, but had lines and everything. And talking to her family, I felt that an arthroplasty was probably the ideal treatment, but this was not the ideal time to do the arthroplasty. So I did something that seemed really crazy at the time, but now we do it a little bit. We call it a girdle stone bridge, and it's not a girdle stone technically, but resection arthroplasty of the hip with the intent that we will bridge that to arthroplasty. But when you do this, there's no hardware, small incisions, a quick surgery. The patient has absolutely no mobility restrictions afterwards. You don't have to worry about dislocating the hip or anything like that. And it just simply didn't make sense to me to do a total hip in an ICU patient who can't get up and walk on it. We did fix some of her other fractures. And I told the family that if she ever got to the point where she walked in and asked for her hip to be done, then we hadn't burned any bridges. And so we mobilized her with no restrictions. She got better. She had her hand amputated, unfortunately. She had tracheostomy. She went off to a long-term care facility. But 2 months later, lo and behold, she actually did walk into my clinic with a walker and said she was ready to have her hip put in. And so that's her x-ray at the time, so some heterotopic bone, but was able to do a total hip. And this is an x-ray at 10-year follow-up. And actually just saw her for a different problem a month ago. And I didn't go get the newer X-ray, but she's now closer to 15 or 17 years out and still walking around on that hip. So we've begun to use that sort of approach a little more often in some of these really unusual cases. Here's a 65-year-old female who fell from a ladder, and a resident who had stayed in Minnesota, worked in a small town, knew everybody, did really not want to be part of trying to fix this fracture, thinking that it would not likely have a good result with internal fixation, and so sent her back to the city, so she could get some advice from trauma colleagues. And this is her CT scan. That lateral is a bit scary, but she has some degenerative changes in the knee, and we talked to her about putting her in an external fixator and kind of seeing how she did. Her skin was not perfect. She didn't really like the idea of having a knee replacement, and we'd had some other experience with patients like this where we do some damage control with an external fixator, and then they actually do well with just that. So we decided to treat her in the fixator. My protocol for this is to leave the fixator on for 8 weeks, take them back to the operating room to remove the fixator and do a very gentle manipulation. And this is how she healed, and that lateral X-ray especially looks awkward, but she actually is doing fine. She goes to the wellness center and works out and, quote, doesn't have any problems, and I have several years of follow-up on her. So occasionally this kind of conservative approach that you learn from some of the pitfalls of treating these fractures, can be beneficial. We touched on this morning, and this has been a real interest of ours at Hennepin, is the geriatric acetabular fracture. So I showed our first case, the woman that was rollerblading. This was another patient that came in around this time. This patient was 97, presented with this X-ray. There's really no good way to fix that. She's not going to do well with non-operative treatment. I've seen some patients that are left alone like this. Their femoral head gets incorporated in the fracture callus, and they actually get a secondary femoral neck fracture because there's no motion, that occurs, and they're being transferred to something, and then their hip snaps, and we have to deal with that at that time. But we know these patients are going to have a predictably poor outcome with non-operative management. They're going to have high complications and likely reoperations with operative management. So our premise was, well, if you're going to do a total hip anyway, why not just do it in one operation? And we began with some of the simple cases. I showed you that anterior wall. Here is a patient with a posterior fracture dislocation, and you can see the large impaction injury in the femoral head. That's what it looked like after we did the resection. But these patients, particularly the posterior dislocations and the cases we saw earlier, where some people refer to as central fracture dislocations, they're just going to have poor outcomes with non-operative management. So when we started doing this, we utilized our trauma principles that we were going to classify the fractures the same way, decide what approach to use the same way, fix the columns the same way, and then just under the same anesthetic, do a total hip with uncemented components and bone grafting. Sometimes if it's primarily a posterior column fracture, posterior column, posterior wall, some transverse fractures, you can do everything from the back. Sometimes we would have to do front and back, but the front component was typically done fairly quickly because, again, the reduction requirements are not like you're doing an acute fixation. So we started doing these cases, as I said, in 1996. You can see how we sort of ramped up slowly. And actually, I haven't looked at the actual numbers, but I think we're still probably around the half dozen cases a year, one every 2 months. So we're not doing this by any means in every geriatric acetabular fracture, but in a patient that's a good candidate for it, meaning that they're fairly independent and have high or even just normal sort of functional goals to remain independent. We found it to be a good approach. So I looked up with Carol Lynn, whose name came up a little bit earlier. She was with us that year in a research position. We looked up the 29 cases we'd done up to that point, and you can see the age range had snuck down to 45. So we'll talk a little bit more about that next. Those are posterior wall fractures, but typically the patients were 66 with a widespread. We had 2 years, a mean of 2.5 years of follow-up, and you can see kind of how we did the cases. We bone grafted most of them, used uncemented cups in nearly all of them, and they all had associated fixation as indicated by the fracture pattern. We had very few, I think surprisingly few complications. There was one patient that had some pulmonary problems. We had a wound hematoma. We had to wash out and reclose the wound. We did have one deep wound infection, but happily we were able to resolve that with aggressive wound therapy. Only had one case where the cup moved, and that was a cup that in retrospect was probably undersized, and I could have done more to stabilized it initially, but it didn't. It just rotated into a vertical position, and then her hip kind of dislocated. But at 6 weeks, I was able to revise that simply to a cup that was a couple sizes larger, and she did well. So Carol looked up the cases. We purposely chose to just look up the ones that had more than 1 year of follow-up. So there were 23 of those. 6 had died when we tried to find them. Of the 17 remaining cases, we were able to find 15 of them, and we administered an Oxford score over the phone and an SF-12 score. And surprisingly, that Oxford hip score of 16.7 is about on par with the Oxford hip scores you get after degenerative arthritis and a total hip. So we achieved good scores. This is the original Oxford score, where the best score is 12 and the worst score is 60, so it's backwards and odd numbers. So a score of 16.7 is actually good. And we did have some patients with perfect Oxford scores of 12. So this is a paper that Carol was first author on, where we reported our experience. And at the time we published this, it was one of the larger series and also had some of the longest follow-up. I alluded to the fact that we were doing some of these in earlier cases, and we've developed the mindset in our femoral neck fracture cases that if you're probably 50 or older, you're best served with a total hip, especially if it's, I'm sorry, I'm talking about posterior wall fractures, especially if it's comminuted, if there's marginal impaction of the posterior wall and this femoral head damage. Those prognostic signs are almost guarantee you a total hip replacement. So when we began to see patients in their 50s and maybe even late 40s who had a posterior wall fracture that had all three of those bad prognostic signs, we were kind of telling them the same thing we tell the patients with femoral neck fractures who also have high reoperation rates, that maybe you want to have a total hip. And so Lauren, Carol started this study, but Lauren was one of our residents at the time. We did a matched series analysis of just patients with posterior wall fractures, and we compared our results with internal fixation to the results with total hip, and these were in middle-aged patients, so kind of targeting at this younger set. And you can see they were matched, by definition, pretty well with respect to age, gender, and fracture classification. They all had posterior wall, and we looked at the acute total hips. There was a bias, though, if you look at the presence of some of the negative prognostic factors. The marginal impaction, comminution, and dome involvement were more prominent in the total hip patients. So we did the total hips in the patients that were likely going to have a worse outcome, and perhaps save the fixation cases for cases that were likely going to do better. But despite that, this is the Kaplan-Meier survival curve, and so on the left table, the fixation are the red hashed lines, and the acute total hips are the darker solid lines. And you can see the survivorship began to decline very rapidly after fixation, and that's the same thing that other surgeons have seen when they fix posterior wall fractures. If they're going to fail, they fail quickly, usually within the first year. And so you can see the survivorship at 2 to 4 years is down to around 40 to 50% in the ones that had primary fixation, whereas with the total hips it remained above 80 to 90%. And then there's also much more predictable outcomes in terms of the Oxford hip scores. And this is a different version of the Oxford hip score, so now high is better. They kept changing the Oxford hip score during the years to make it more consistent with other outcome scores. But you can see we got more predictable results with the total hip and more durable results. So that's an interesting finding. So now I'll switch to talk a little bit about periprosthetic fractures, which is another, I think, fascinating topic that really spans this sort of traumaplasty definition. So this is the unified classification system for periprosthetic fractures that the AO group sort of publicized. But in terms of how you treat them, whether you fix them or replace them, it's basically they've adopted the Vancouver classification, Clive Duncan's approach. So they call them type B fractures. B1 if there's good bone and no loosening. B2 if there's good bone but the implant interface is disrupted, and then B3 is if there's poor bone and the implant is completely loose. So it's very similar to the Vancouver classification for hip fractures, but it all hinges on your assessment of is the stem stable. And as a fracture surgeon and a joint surgeon, I clearly look at these fractures around uncemented stems, I think, differently. I think many of these fractures about the stem are actually stable, or at least ingrown to some major fragment of bone, and so they can actually be treated with fixation. And this is just an example of a case of a 76-year-old woman was 3 years out from having this total hip done from I think she had a direct anterior approach in this small stem, and you can see the fractures that really probably does involve most of that interface on the medial side of her femoral stem. And I'm pretty sure when the residents called me, they described this as a B2, but I never believed them when it's an cemented stem. I wanted to see for myself. And so my assessment was, clearly the stem is out of the canal. It's not attached along the lesser trochanter medially, but it looks like it's completely ingrown to that extended trochanteric fragment laterally. And so I fixed it. And we always use long plates and get screws around in the lesser trochanter, and sometimes, as I did here, supplement with cerclage wires. Like I said, I don't have a follow-up X-ray in that one. This is another patient, so this is sort of different. This is a 71-year-old male who's very active, but he's got a cemented stem, and you can tell that cement mantle is loose, and so he gets a long stem revision. But it's interesting, some other authors are starting to think about this too. So this paper, I think from Boston, was outcomes after operative fixation in patients that they classified as B2 or B3 fractures, so patients that they knew were loose and yet they fixed them. They found that in geriatric patients, even with known loose stems, that ORF is safe and can lead to reasonable outcomes with a much lesser operation. So I think I've been fortunate to kind of live my career during a time when a new specialty in medicine was sort of being developed. Interestingly, my wife is a pediatric cardiologist, but she now does adult congenital heart disease, which is the thing that didn't used to exist, and now is actually you can be board certified in it. I don't think we'll ever have subspecialty certifications for traumaplasty, but this is just the definition of a new specialty, focused on a defined group of patients, diseases, and skills, and a philosophy of treatment, and I think that all applies to kind of these geriatric patients with fractures. So if you look in the literature, you can find all sorts of papers talking about treating acute fractures or complex fractures or periprosthetic fractures with fixation. So it's certainly the focus of a lot of clinical and research work. And that gets to a very interesting topic to debate. That's who should be doing these total hips, whether it's an acetabular fracture or even a femoral neck fracture. And there's several papers on that. So George Hadokavich is in my vintage. I remember we're, I think, about the same age, and he did the Tampa Trauma Fellowship, and then, but I think quickly pivoted his career mostly to arthroplasty, although he still does some trauma work. But they looked at essentially 150 total hips that were done for displaced femoral neck fractures, and looked at implant survival and complications at 90 days and at 1 year, and found that the major surgical complication rate was much higher when trauma surgeons did the total hip compared to adult reconstruction surgeons, which makes me feel a little sad, but that's what they found. The arthroplasty, the adult recon surgeons were far better at positioning the acetabular component, so they had far lower rates of component malpositioning, 12% versus 3%. Mortality and readmission rates were similar, but again, importantly, the implant survivorship was higher for the adult recon surgeons doing acute total hips for femoral neck fractures. Here's another sub-study of the health study. This is a multi-center international study that was done on hip fractures, looking at hemiarthroplasty and totals, and so a lot of patients, and they knew they retrospectively assessed the surgeon's training, and then they compared outcomes, similar to the last study. But again, if you look at the really important things, for example, unplanned secondary surgeries, dislocations, or prosthetic joint infections, the adult recon surgeons were better than the trauma surgeons in every one of those categories, and especially for prosthetic joint infection, the odds ratio was nearly 4. It was lower for the other complications, but again, suggestion that the recon surgeons are better. And then here's finally a paper from Alabama, again looking at the same problem, and again coming to the conclusion that especially with prosthetic joint infection, the arthroplasty surgeons did better than the trauma surgeons that do an acute total hips. So I think this begs the point that we should be training trauma surgeons to do acute total hips, because they're often the ones that are going to be there when they have these displaced femoral neck fractures and acetabular fractures. And I think just from the logistics standpoint of providing medical care, that they're going to need to know how to do these, but clearly have some room for improvement. And ideally, you would be able to have a surgeon that at least does a high volume of arthroplasty and is familiar with some of the arthroplasty protocols to be involved in the care. So we'll get on to the last section of the talk, which gets into some of the, I think, the career sustainability, maybe wellness aspects of this. So, where you've all heard this quote about if you love your job, you never work. So there's nothing better than, young 18-year-old who comes in with all these fractures that we can just spend a day in the OR, just ignoring the rest of the world and just fixing these fractures. But to be able to do that over the course of your life, you've really got to treat yourself like a high-performance athlete. So you've got to be adequately rested. You've got to pay attention to your nutrition. You've got to train mentally and physically. But a trauma, any practice is hard. Trauma practice is especially hard because of the nights and weekends that are involved, and the patients are demanding. You don't get immediate gratification. You have to wait months and years sometimes to get things to heal. And so when I talk to our trauma fellows and our residents interested in trauma, I recommend to all of them that you should maintain or develop a second skill set. That will do a number of things. It's great for your sanity. But actually, if you ever face a job change, and in orthopedics, a lot of our colleagues change jobs for various reasons. And if you have a second skill set besides trauma, that's going to make you more marketable for a practice manager or senior partner, whoever's trying to decide whether to hire you or not. When you do trauma, you're going to have ups and downs in your volume, which drive hospital administrators absolutely crazy. Every single April, I have to argue why trauma is slow in Minnesota in April, and they shouldn't be worried about it, but they do. And but if you can keep going with something else, so for me, my joint practice that I do one day a week, kind of smooths out the ups and downs of the trauma practice and keeps my RVUs up. Also, if there's something that affects your elective practice, like a global pandemic, where you can't do joint replacements, the trauma can keep you going. So those are just examples of things where they complemented each other. But very importantly for me, I had this a couple years ago. I couldn't take trauma call for a year while I dealt with a medical issue, and that arthroplasty practice I was able to keep doing. So that was important for me. It was important for my family because my wife didn't have to worry about me just laying around at home not doing anything, and I felt good because I was able to continue my administrative role with my partners, but even more so I was still able to do some of those periprosthetic fractures and some of the cold cases like we talked about. So another good example of why a career like this, bridging kind of two different specialties, is good. So I think just to briefly summarize, many older trauma patients do benefit from arthroplasty for their immediate fracture and or treating complications of those fractures, and it's clearly something that demands multidisciplinary approach. And it's something that a single surgeon can do both. You can also develop those kind of relationships within the department that facilitate that kind of transfer of knowledge and skills. But a traumaplasty surgeon can bridge the gap when someone needs arthroplasty. It can be more efficient than having two entirely independent services. Some institutions like ours can't have a separate arthroplasty service and a trauma service. And I think it can offer the patient the best of both, as I showed some of those cases where kind of having decision-making, experience in decision-making in both specialties kind of may help you choose the best course of care for a certain complicated patient. So hopefully that was of interest to you. That's supposed to say thank you and questions or comments. I think we probably have a few minutes.
That was a great review of your experience, and I'm sure there are some questions, and we have a few minutes for some questions. I wanted to start out, and you alluded to this a little bit in your talk, some context. Tell us a little bit about Hennepin. Tell us about the environment, and then how you actually maybe integrate pathways for a trauma patient versus a total joint patient. But what's it like? What sort of support do you have in the environment where you're working?
Well, yeah, that's an interesting question. I alluded to this at the beginning. Some of it is the institutional culture that Ramon and Dick, had sort of established, where they were both taking trauma call, but then both having these big long OR days where they would do total joints. So we had operating room staff that had the skill set for both. Anesthesiologists that were kind of used to both, physical therapists that were used to both, and it was fairly easy to kind of integrate them. And the other thing I think was Hennepin is a unique institution that it's just a freestanding hospital. So we're affiliated with the University of Minnesota, but it's just, there was a time when there were only 5, 6 surgeons. Now we're about to go up to 11, but it was just a small group of people kind of doing everything. So there wasn't a lot of institutional, issues with doing these things. We've tried to standardize, protocols for DVT prophylaxis, for example, in trauma patients and joint patients, and with Epic, standardized order sets and all those sort of things. But really, when it comes down to it, when we have these cases, we've always had a kind of a departmental culture of sharing things back and forth regardless. Some trauma centers, the person on call just has to, that's their patient. But we always have shared things, and I call them project patients, where they'll have multiple injuries. They might have a plateau, a pelvis, a shoulder, and our pelvic. We have 2 surgeons who are real good at the pelvic fractures. They'll do those. I might do the plateau. Our upper extremity surgeon might do the shoulder. So we've always had that kind of ability to engage the whole group in that regard. And when we have these periprosthetic fractures, that's exactly kind of what happens. And if the decision is to fix it, I might do it, but it could also just be one of the, Gruden might fix it, or one of the trauma folks. If it's arthroplasty, then it's either Dick or I, or we have a third traumaplasty surgeon. But the size of our department facilitates that, the institution itself, and it's kind of its culture sort of facilitate that as well.
That's great. Sounds very familiar. It's nice. There are other questions. I do have one. This issue of acetabular trauma, pelvic trauma, and doing it full hip. And the case you showed was almost identical, the X-ray to the one we discussed this morning. And I'm wondering, this requires a very unique skill set. You need live bone, you need a stable base to get it cupped in securely. Just thinking about practice doing these cases, how often are you trying to get the cup in and then you have to go back and move the plate or change the fixation? Is there much back and forth, or are you just really doing the fixation and then doing whatever you have to do?
Yeah, we haven't had to happily, go back and redo the fixation. I think it's for several reasons. One, again, having experienced trauma. So early in my career, whenever we did these, Dave Topo and I would scrub together. I've gotten to the point now where I pretty much do them on my own, but the anterior fixation is far simpler than if you're trying to do definitive fixation in a young person, because you're just trying to reduce the major displacement in the column and get something that's going to provide sort of a buttress. I just tell the residents I want something to hammer against when I'm impacting the cup, but you keep the hardware away from where again having a single surgeon is good, because you know where you're going to need to get screws for your pelvic for your acetabular component. You kind of know what the important bone is that needs to be stable. You know what needs to be reduced, what doesn't need to be reduced, and we can but this took 20 years, to get where we are now. It just didn't happen overnight. There's a lot of trial and error and things, and but it again was applying kind of expertise of the trauma to the arthroplasty. So.
Thanks for your great talk. I listened to it and I got a little bit sad because I operate in an environment where I have such talented partners. I mean, phenomenal arthroplasty surgeons. Actually, 2 traumaplasty surgeons who are sitting over there who are dual fellowship trained. So I guess I'm going to have to find something else to be another thing as I age to promote wellness in sports. My question to you is this: that despite this really embarrassment of riches of talent around us, I think we have been a little bit more conservative than you guys in adopting a traumaplasty approach. We often have these wonderful academic discussions and quote literature about what should be done for various things, and we often go the route of fixation. And I'm wondering if, in the setting of geriatric hip fractures, either acetabular fractures or distal femoral fractures, where do you find the biggest bang for your buck for folks who are maybe a little bit earlier in the curve in adopting these approaches? I mean, it clearly seems like posterior wall involved acetabular fractures, and I would agree with that with my own experience, are the worst actors in terms of rapid degeneration of the joint. But where do you see the greatest opportunity for those of us who are maybe a little bit slower in adopting this approach?
Yeah, if I think what I learned in my nearly 30 years now and kind of condensing that into a few years, starting out with the simple cases, it's like posterior column, posterior wall fractures are it's a single approach and the fixation's right there. If you're doing the more complex cases, the intercolumn hemitransverse or the intercolumn fractures, you want to have someone who's got experience doing that fixation that you can work with, and then you can add it on pretty quickly. The distal femur replacements it's a pretty easy operation. The hardest thing for me is the rotation, but when you've done revision knees, and you just you rotate the femur based on your tibia inflection, you can use that, and getting length isn't so hard. So distal femur replacements it's an impressive X-ray, but it's actually a pretty simple operation. The problem is just so darn expensive. So that's one reason why we avoid those at our place, because they're $50,000-$75,000, I think, even for the components almost. But again, you get the patient walking right away, and there's a lot of benefits also. But yeah, I think picking out what your skill set and your institution can support and starting there is the way to do it.
Really enjoyed your talk. I remember the picture of the paraprosthetic fracture. It was stuck to the lateral piece with the shaft extension. And so when you're making decisions on whether or not to fix those, because there's a big hunk of bone clearly ongrown to the implant, do you have rule of thumb on like how much ingrowth you need, how big the piece of bone needs to be to kind of just reconstruct it with, or if it's instead of doing a revision? Yeah,
and that approach comes from my experience revising joints and doing an extended, trochanteric osteotomy, and having trouble getting that to come off the prosthesis, and then staring at the prosthesis laying there and having to spend another 3 hours still chiseling it out because it's so ingrown on the backside. So it doesn't take a lot of bone to be ingrown. And I remember some studies early on that said that when you do an ingrowth stem or ingrowth cup or stem, you often only have 30% ingrowth on 30% of the surface area. And maybe better now with current hips, but or current prosthetic coatings and such. But I think if you've got the trochanteric fragment, if it's big enough fragment, you can get screws into it, then I think you can fix it. Because if the fracture heals and the component remains ingrown to that one piece, you're probably going to have sufficient stability, and that's what our experience has shown. We're trying to kind of collect these and look them up, and I think that paper that they published from Boston, I believe it was, that showed that even when the stem is loose, that these geriatric patients, they're just low demand. They could walk to the bathroom, and you don't have to put them through this big revision operation. So I guess that's my answer: is if the piece is big enough to fix, because you've got to be able to fix it with something. And for the pieces that are not ingrown, do you do anything with the fibrous membrane? Do you bother with that, or do you try to strip it and try to get more bone exposed, or do you just stick it back together? I've not done that. We try to, again, this goes back to the fracture experience, just lateral approach and just kind of trying not to disturb the fracture hematoma and doing as much closed reduction as you can, the same way we might if we were going to treat it with an intermedullary nail or something. We use that long plate, and I've always found that with those latest generation paraprosthetic fracture fixation plates with eccentric screws, you can always get a screw posterior to the stem into the lesser trochanter. Like I've ever not been able to do that. So even sometimes that's the only screw you get, but that with a long plate gives you good stability, and sometimes with cerclage wires. But if I can get a screw just distal to the fracture, right in the lesser troch, and then reduce the rest of it the same way we reduce a fracture, they heal pretty well.
Thank you.
Just one observation, some caution on it. If you can get a screw in it, then you can fix it. Looking at all these x-rays on Monday morning, I'm impressed that, I don't know if Luke is here, there's not a bone piece that's too small to put a screw in.
That's true.
So that's pretty impressive what a traumatologist can do. Tom, yeah.
Just one last thing before we go to lunch. I can't remember ever having a discussion of work-life balance at this program. I don't know, have we ever had that before?
But we have two today.
Yeah, so as many of us are towards the end of our career, I just want to compliment you on that. And also for the younger folks here, listen to that, because as you said, when we go to work, we're not really working. We're having a great time. I say to the residents sometimes, we're going to have a great day. This is going to be a lot of fun. And we go home, we might be tired, but it really wasn't work. And if you can keep that attitude, it makes our lives so much easier. And I think that, thank you so much for presenting that. It's just a wonderful concept.
the back quarter there, they call that flow, right?